just going to go through the epidemic a little bit and chronic pain management and primary care, and then I have 3 case studies at the end of it. Does anybody have a guess as to what percentage of primary care visits have either a primary or secondary complaint of pain? 70. Any other guesses? 95. 40. 40. So I put that in there just to make a point that it is really common. So you guys are going to be seeing this every day in primary care. So it's important to get comfortable with chronic pain management and different opiates and prescribed opiates as well. Pain is the most common cause of disability in the United States, and only 2% of chronic pain is managed by a pain specialist. So there are pain specialists out there, but it's mostly on primary care providers. So you guys probably remember the pathophysiology of chronic pain a little bit from previous classes. But interestingly, we really don't know that much about the different types of chronic pain and how they work. And there's a lot that we don't know, even though pain has been studied for a really long time. In general, you're going to probably see a lot of patients in primary care that have neuropathic pain. So that could be from damage to either the peripheral nervous system or the central nervous system from a disease or other condition. So in general, the nerve fibers are sending pain signals even though the original injury was already healed. And then nociceptive pain is more like what you would typically see with an acute injury. Different people classify pain a little differently. There's different ways of breaking it down. But in general, chronic pain is usually defined as lasting more than 3 months. So if you have somebody that has acute pain, you can manage that differently. When you have a patient with chronic pain, it's really important to accept the patient's report of pain. There's a lot of stigma associated with chronic pain, so a lot of patients are going to already be feeling like you're not going to believe them, or you're not going to believe how bad their pain is. So it's good to communicate that to your patients, that you believe them, you know that their pain is real, and you're going to work with them to manage their pain. It's also really important to be consistent with all patients and use a standardized approach to chronic pain. And collaborative decision making is really important. So with all chronic pain management decisions, you should make sure to talk to your patient and counseling them about the different choices and trying to make decisions together as a team. It's a good thing to be aware of upfront before you go to practice that some patients will come in and just demand a certain medication, but that's not the approach you should take. So if someone does do that, you should redirect them and sit down and have a conversation about what might be the best pain management strategy. Related to that is also informed consent and evidence-based practice. This could also keep up to date with research on pain management. It's always changing, and that way you can counsel your patients on what we know and what we don't know. When you make a pain management plan, it's really important to not just have medication, but to also have different modalities. So using non-pharmacologic methods as well, and then setting smart functional goals for the patient. So you should have a full visit where you sit down with each patient and make an individualized plan of what their goals are going to be. And that is really important because that will guide your assessment of the treatment over time. So if you do that up front, then 6 months later or a year later, you can look back on that original plan and say, okay, did we achieve those goals, or is this not working how we thought that it would? And then part of that conversation also should be when you will stop therapy if something isn't working. You define those parameters, then you can talk to your patient about what it's going to look like if the therapy is working versus what it's going to look like if it's not working. And it's good to also integrate psychosocial support and other resources. So if you have like a social worker in your clinic or other people on your team, it's better to get everybody involved in the management process. For chronic pain assessment, there's a number of different tools out there. It's good to pick one that meets the needs of the patients that you're seeing. Some of them are a lot longer and some of them are shorter. I put the brief pain inventory on the CLE. I think that one's really good for primary care because it's pretty concise. So it's something that you can use quickly in a clinical setting. Some of the other ones are a lot longer. For example, if a tool takes like 25 minutes to complete, it might be less practical to use in a primary care setting. It's good to get a really thorough HPI about the pain. And you also want to try to review past medical records, including the imaging from previous providers. And assessing mental health is a really important part of that because pain and depression often go hand in hand. The prevalence of depression among chronic pain patients is anywhere from 5 to 58%, which is a really, really big range. And that's because it depends on how you define it. So some researchers say that you can't have overlapping symptoms. So if something on the PHQ-9 is positive because of the patient's pain, they exclude that. Whereas some people say depression's depression, it should all count. So that's why there's this big, it's kind of debatable, like how much of this really is depression that's going along with chronic pain. But either way, I think it's really important to assess whether that means you're going to treat it differently. It depends, but it can be really helpful to know what symptoms your patient is having because a lot of the medications that you can choose for chronic pain have properties that can also help with mental health symptoms. So a lot of the time, if a patient is having a lot of depression or a lot of anxiety, you might be able to pick a drug that's going to work for both the pain and those other symptoms. It's important to get a really thorough physical exam as part of your initial pain assessment and focus on musculoskeletal and neuro. You should usually get some basic labs, but a lot of them are going to be individualized based on what type of pain it is that you're assessing. So if it's peripheral neuropathy, that's going to be a little bit different based on if it's a musculoskeletal complaint, for example. It's good if you can diagnose the cause if possible, but a lot of the time it may not be totally clear. And a lot of the time there's going to be other contributing factors. So life stress or depression or anxiety, there could be all these different things in the patient's life that are adding to their pain. So it's good to talk to the patient and get a whole picture of the person because a lot of the time pain isn't just one simple thing occurring in isolation. Imaging isn't necessarily part of your chronic pain assessment. It really depends on the individual patient. So diagnostic testing shouldn't be ordered initially for lower back pain. The American Academy of Family Physicians has the Choosing Wisely campaign. Are you guys familiar with that? No. So you can go online and look at their information. The gist of it is it's trying to get clinicians to order less unnecessary or low quality imaging. So trying to reduce how much radiation we're exposing patients to. So it's a good resource to look at because it'll help guide when you should and when you really shouldn't be ordering imaging. So a lot of radicular symptoms with low back pain will actually resolve on their own after 2 weeks, and most herniated discs also will resolve in about 8 weeks. So even if you think you know what it is, you still might not necessarily need to send a patient for an MRI. A lot of those are just going to resolve on their own. Another note about your chronic pain assessment is remember, if it wasn't documented, it wasn't done. It's really important to make sure that all of this is in your initial note before you start treating someone's chronic pain. There's a lot of different non-pharmacologic pain management options out there. Some of them have better evidence than others. In general, it's great to always try to use a multidisciplinary team approach. Exercise and physical therapy have a lot of good evidence to support their use. Thermal therapy and trigger point injections and other injections like steroid injections, there's some evidence for a benefit for chronic pain. Transcutaneous electrical nerve stimulation, unfortunately, there isn't good evidence for. I've had patients who loved it though, and that one, there's really no risk. So if they want to try it and it seems to help them, say go for it. But the data on it show that it doesn't actually cause a long-term improvement in pain or function. And massage, similarly, there is a short-term benefit, so people will feel better for a little while, but long-term studies have shown it doesn't actually improve pain or function. But again, massage, there's, I think you always have to weigh risk benefit. Like there's really no risk for someone to go get a massage. So if you want to include components like that in your treatment plan, that'll make it a lot more well-rounded. And studies have shown that patients are more successful when they have multiple different therapies. So if you have like 3 different things that you're doing for chronic pain, that's going to be more effective than if you just pick one. So even though the evidence for some of these isn't great, it's better to include them to make a stronger treatment plan overall. Acupuncture, similarly, there's a little evidence, but it's not really that strong as far as long-term pain control. Spinal manipulation for lower back pain, studies have shown there's short-term effects for reducing pain and improving functional status, but insufficient evidence to support spinal manipulation for other conditions. Kind of cautionary tale is I once had a patient who went to a chiropractor for something not related to chronic pain. It was for brucellosis, actually. But most chiropractors believe they can cure anything by manipulating the spine. So this guy then was seeing me after getting discharged from the hospital because he had had a therapeutic spinal tap and had a CSF leak and collapsed on the ground out in the town and had to be taken in the emergency room, had to be repaired with a blood patch. So a lot of these practitioners they do a much wider range of things, and most of them are not evidence-based. So spinal manipulation for lower back pain, like you can recommend that for your patients, but I think it's a good idea to counsel patients on potential risks of going to practitioners for other things that are outside of the scope of what we have evidence for, because a lot of those treatments could be harmful. And then yoga and Tai Chi have a lot of good evidence. In general, there's a lot of evidence to say that active treatments are more beneficial than passive ones. So if you can get your patient to do yoga every day, that's probably going to be more effective than something where they're not actively participating in their treatment. And then socialization can be really helpful. So a lot of people with chronic pain end up becoming really isolated because it's hard for them to get out of the house, and a lot of them have depression symptoms or depressive symptoms that go along with that, and that can actually make pain worse. So there's a lot of evidence that the psychological side of pain has a real influence on how severe people's pain is. So it's important to address that too. And then if you do have a patient that you can diagnose with depression, you should be treating that at the same time. Because if you just focus on physical pain, it's not going to be as effective as if you look at the whole picture of what's going on. On this slide, I color-coded, so green are drugs that I thought you guys should be more familiar with. So those are ones that I'd recommend. If you don't know those drugs already, look them up, get familiar with them, because you're going to use those more, because there's more evidence to support those in general. But at the same time, acetaminophen overdose is the leading cause of acute liver failure in the United States. So all of these drugs have potential harms. So it's always good to counsel patients on the risks of everything, not just opiates, because a lot of these could have side effects, especially if you're using them at high doses over many, many years. And a lot of these are actually adjuvant medications, meaning that they were developed for something else, but they have pain-relieving properties. And some of those are now first-line medications for some types of neuropathic pain. So gabapentin is a good example of that. Also nortriptyline. So a lot of these we used to use for depression or as an anticonvulsant, but now they're first-line treatments for chronic pain. A lot of these kind of outside of the traditional scope of pain management, but they can be really helpful for a lot of patients. Oh, and then botulism has been shown to help sometimes for like if someone has post-herpetic neuralgia, for example. So that's not something that you would use as much in primary care, but you could certainly refer somebody for it if you have a patient with post-herpetic neuralgia or something like that, where it's not responding to other therapies. Yes, yeah. So I just wanted to go over the history briefly, just to put this all in context. I think it's important for you guys coming into practice to be familiar with how we got to where we are now, because you're going to be encountering this, and it's good to know, what the bigger context of it is. The Harrison Narcotic Act in 1914 required prescriptions for addictive substances. So that was kind of the beginning of figuring out controlled substances. And then the Comprehensive Drug Abuse Prevention and Control Act organized drugs into 5 schedules and required pharmacists to maintain records for certain types of drugs. And then in 1988, the Anti-Drug Abuse Act created the Director of National Drug Control Policy as a position to control drug abuse and diversion. And then in the late 90s, there was a national shift of attention towards undertreating of pain. And that's what prompted the Joint Commission to establish standards for pain. And along with that, you'll often hear people talk about being told that pain is the vital sign and all this kind of redirection towards focusing on pain. That was all around the late 90s and early 2000s. At the same time, a lot of pharmaceutical reps were being paid to spread a lot of information that we now know is completely false. One example was Purdue Pharma had representatives that were saying that less than 1% of patients prescribed an opiate will become addicted. So we now know it's closer to 25%. But that was national information. So a lot of people believed that at the time and were prescribing these drugs thinking that they were completely safe and there was very little risk. Similarly, a lot of people believed that patients wouldn't get addicted if they had any real pain. And that's something you may hear people repeat still to this day. Like a lot of patients will say, oh, but I'm not going to get addicted because I have pain. So it's important to counsel people on, well, actually, it can happen to everybody. We're all at risk. It's not just the certain group of people, because a lot of people got kind of labeled as like, oh, well, those are, the people who are addicts. And that's really not helpful because it stigmatizes people who have an addiction. And it also makes people think that they're not at risk if they aren't part of that group. In 2017, 17.4% of the United States population received 1 or more opioid prescriptions, with the average person receiving 3.4 prescriptions. So the scale of this is really unbelievable, how quickly this escalated. And then I also wanted to mention that there's disparities in the impact of the opioid epidemic. So it hasn't hit all parts of the population equally, and it also hasn't hit all parts of the country equally. So opioid overdoses increased by 70% in the Midwestern U.S. from July 2016 to September 2017. So a lot of the Midwest has been hit really hard with this, and pretty recently. And also prescription overdose deaths among women increased more than 400% from 1999 to 2010, compared to 237% among men, which is interesting, I think, because that's something that I wouldn't have intuitively thought was the case. I feel like in general, we often think of men as taking more pain relievers than women, but that's actually not the case. It's the other way around. I mentioned, I think, storage, or at least I have that on one of my slides, but the first point really, I think, speaks to that. It's really important to talk to all your patients about keeping their medications in a place where their family members, their neighbors, other people aren't going to be able to get to them, because it's very common for people to have unused medications in their medicine cabinet or, just around their house, and then a family member or someone who's over at their house will take those, and that's often how people start using prescription opiates. I think it's also important to recognize the last bullet point that the amount of opiates prescribed quadrupled from 1999 to 2013, but there's been no decrease in the amount of chronic pain reported by Americans. I feel like that's really interesting, kind of step back and think about. Like, we have this huge increase in how many opiates people are taking, and chronic pain has stayed the same. So I think you can really read a lot into that. What does that really mean on the patient level? This graph shows that the prescribing of opiates actually has been decreasing a little bit since 2010. So this is kind of the positive note of all of this is on the medical side of things, we're seeing signs of improvement. So it is consistently going down, and high-dose opiates are also going down. So a lot of the medical communities finally started to change practices and started to recognize that high-dose opiates are not always the best choice and not always safe. If you think about that last graph where 2010 was where the decline started, and then comparing to this one, you can see that prescription opioids on this graph also do, for the most part, level off around 2010, but you can see that that's obviously not going to solve the whole problem. There's a whole other thing going on here. It's a much bigger problem now. It's not just about opiates, it's about all these different drugs. So people are overdosing on a range of things, and the magnitude of this epidemic it's become way greater than the prescriptions. It's not like we were prescribing too many things and then we can just taper that down. It's gone way past that. Mm-hmm.
What's the difference between opioids that are acquired from the street and versus the opioids that go to so high?
Do you mean as far as data, like how many people
the
are
risk of overdosing?
So in general, fentanyl is much more potent than a lot of the ones that we commonly prescribe, although we do have pharmaceutical grade fentanyl as well. So the risk of overdose is certainly higher with more potent substances in general. And one added risk with things that are not pharmaceutical grade is you don't always know what you're taking. So if you go buy something and you say, hey, I want to buy heroin, you might actually be getting fentanyl, or it could have some carfentanil in it, it could have some cocaine in it. You could get all sorts of things mixed in that you weren't expecting and you weren't intending to take. So that's one of the reasons for overdoses, because people who are used to using one drug, so let's say they've been using heroin for a long time, they know exactly how much heroin they want to use, they go buy something and then they overdose by accident because it wasn't what the person said that they were buying. Fentanyl is really driving the recent spike in overdoses. That's compared to the last graph, that's one of the main contributors to that recent increase. And as you can see, overdose deaths are now a bigger cause of accidental death in the United States compared to suicide, car crashes, murders, or gun violence. So in general with fentanyl, a lot of the precursors are being manufactured in China, and then they're being shipped either through Mexico or sometimes through Canada, and occasionally directly into the United States, and then they're processed into what's then sold on the street. So there's this supply chain going on. It's now global that's driving the epidemic. So this is not just a United States problem. It's a lot bigger than that geographically as well. This slide, I grouped different drugs to try to show that a lot of these are prescription drugs that you should be very aware of, especially because if they're used in combination, they can be harmful. For example, benzodiazepines are rarely lethal on their own, but increasing amount of lethal overdoses now are benzodiazepines with two or more other drugs. So, for example, someone might be taking benzodiazepine and also a skeletal muscle relaxant and a stimulant, or some combination like that, or an alcohol is another one that gets added in to a lot of overdoses. So it's important when you're prescribing other drug classes to also be thinking about this, because the opiate epidemic isn't just about opiates, it's about a lot of different drugs. And as prescribers, you have a responsibility to be counseling all of your patients on the potential risks. And also, you should be thinking about the fact that, let's say you're prescribing someone Ambien for sleep, you should also be having a conversation with that patient about what else they might be using recreationally, how much they're drinking, all these other things that could contribute. Because even if you're only prescribing one thing, it could end up being one of four things that could contribute to overdose. From 1996 to 2013, the number of adults prescribed a benzodiazepine increased by 67%, while the quantity filled more than tripled. And during that same time period, the overdose death rate from benzodiazepines more than quadrupled. So that will show that benzodiazepines are actually a huge factor in what's going on, even though most people just talk about the opiate epidemic as if it's only opiates. But benzodiazepines are really often a dangerous drug class, so we should always be thinking about that. Opana, that's crossed out there. So the reason why that was discontinued, that had a formulation where it had like this coating on it that was supposed to be tamper-proof, and they marketed it saying, oh, no one can abuse this, it's totally safe because it has this special coating on it. But people figured out, initially people were crushing and snorting Opana before it had that coating, and then when they added this coating, people stopped being able to crush it as easily to make a powder. So then people started cooking it and injecting it because a lot of people were already addicted to it. And so when the pharmaceutical company changed the formulation, everybody was kind of stuck because they were already using this. All of a sudden it changed. So they changed too. And with that shift in Scott County, Indiana, more than 200 people got infected with HIV in just that rural Indiana county because all these people immediately switched from snorting to injecting. And that county didn't have needle exchange programs. They didn't have any of the public health services that you might find in a city because it's a rural Indiana county. You know, they didn't think that that was a problem there, but it became a problem very quickly. And then tramadol and tapentadol are both a little bit different from the rest of the opiates because they're dual action mu opioid receptor agonists and norepinephrine and serotonin reuptake inhibitors. So with a lot of these, if you're trying to pick an opiate for a patient, it's good to read about them and think about your particular patient and how different aspects of that particular drug might work with your particular patient. Because a lot of these are a little different, so it's good to read about each one if you're thinking of prescribing one. One thing to remember with opiate side effects is sedation will occur before respiratory suppression does. So if you have a patient come in and they appear sedated, that's a really important red flag that you need to decrease their opiate dose. Because a lot of people will be sedated for a while before they overdose, especially if it's someone on chronic pain management and taking the same dose consistently over time. Some of the reasons why you might not want to prescribe opiates, we don't have any evidence to support that they're effective long term, and that's both for pain and for function. But we do have evidence that other treatments are effective, and a lot of studies have shown that if you taper patients off of opiates, their physical function improves consistently. So that's one thing that we do have good data on, which I think is, again, really interesting to think about on a larger scale of, a lot of people's physical function decreases, and yet we keep giving them the same drug because we're not really thinking about their whole life. Like if you ask patients about what they're doing during the day and what their goals are, it helps shed light on some of those issues because then you might realize, for example, that they're not able to leave the house because they're so sedated. Another thing related to that is it's really helpful if you can talk to a family member for your chronic pain patients. Like I've had a lot of patients where they seemed fine in the office, they didn't seem sedated, but then I asked their spouse and they said, oh yeah, she's sitting in her chair all day, and she falls asleep several times a day, she doesn't even get up, and the patient doesn't even know that necessarily. They might think, oh no, I'm doing fine, but someone else outside of the situation can more easily see objectively what's really going on, so that can be really helpful information. Patients prescribed an opiate for more than 90 days have 122 times the risk of opioid use disorder compared to patients not prescribed an opioid. So again, that really speaks to this is a very real risk to consider. And the longer patients are on opiates, the higher the risk is. Opioid-induced hyperalgesia. I put an article up on the CLE if you want to read more about this. I thought this was really interesting because back in the 1800s, you read these two quotes, like they already had it figured out back before 1800. I just think that's amazing. And yet today, like if you guys look on UpToDate, look up opioid-induced hyperalgesia on UpToDate, and the wording of it is very skeptical that it even exists. Which it kind of is baffling to me that it's like, okay, these doctors in 1870 and 1880 were writing this. Meanwhile, today, up to date is like my favorite source of information. It's usually great, but we've got sources like that still are, saying, oh, maybe it exists, maybe it doesn't, which I think is just kind of crazy. And you'll see it in the clinical setting if you haven't already. It's definitely real. It's definitely affects a lot of people. So it's important to be familiar with and have some understanding of. But what that article that I posted explains is the pathophysiology behind the mechanism for opioid-induced hyperalgesia is not well understood at all. There's at least 5 different theories for why it happens and how it happens. And they've done studies on animals that have shown that there's a progressive reduction in baseline nociceptive pain thresholds with repeated administration of morphine, fentanyl, or heroin, which is really interesting because that explains the mechanism to some degree in humans. But when they try to look at the same thing in humans, not all humans respond the same way. So if you have a whole bunch of rats and you administer morphine to them, you can test their pain and they all respond this way. But in humans, not all humans do. It's much more complicated than that. Some people do, but some people don't. And part of that ties back to the data that like psychological health and psychological symptoms tie into it. So, for example, loneliness contributes to lower pain thresholds. So there's all these factors with humans that rats don't have in the same way that make this a lot more complicated to assess. I just wanted to have the definitions up here because I know sometimes that can be a little confusing. So addiction is a chronic relapsing disease characterized by compulsive drug-seeking behavior and use despite negative consequences. I think it's helpful to think of addiction as a behavior, whereas tolerance and dependence are more just the biological aspect of what's going on. So some people don't have addiction even if they have dependence. And that's an important thing to remember. There's some people that will not have any of the behaviors associated with addiction, even though they will get signs and symptoms of withdrawal if they stop the opiate because they're physically dependent. In 2015, only 10.8% of Americans who needed substance abuse treatment received treatment. So right now, with this huge epidemic going on in the United States, we haven't been able to expand treatment to meet that need. So there's a huge unmet need right now, and it probably will continue to grow because overdoses are continuing to grow. The epidemic, even though prescriptions have started to tailor off from 2010, overall it's not tailoring off yet. So this is probably going to be a growing problem for years to come. So as a nurse practitioner, you can take a 24-hour training through the American Academy of Nurse Practitioners online. And then you can submit that you're qualified to prescribe Suboxone through the Substance Abuse and Mental Health Services Administration. And then the DEA will reissue you a new DEA number with an X instead of the first letter that was in your DEA number. And then you can start treating patients with Suboxone in primary care, which is really great. So methadone is managed much more tightly. Methadone can only be prescribed in special clinics, and patients have to show up every morning. It's very tightly regulated. But with Suboxone or morphine, you can give it to patients in the outpatient setting. So I think that's a great way to help increase access to treatment because there's a lot of primary care providers, and as you saw previously, a lot of people who are experiencing opioid use disorder are coming to primary care for help. So I think it's kind of up to us professionally to step up and be able to provide more of those services.
Do you give like induction for Suboxone?
Yes, yeah. So the class that you take online goes through that in detail, which is really helpful. So yeah, if you take that class once you get your DEA number, like it's not like I did it one weekend. It's pretty easy.
So primary care provider can do the induction as well.
Yeah, yeah. So that's why I'm telling you guys because you all can do this. So you get your DEA number and you take this online class, and it goes through step by step how to do inductions in your office or in your clinic, so you can treat your primary care patients in an outpatient setting. So that's what I think is so great about this is it's expanded so NPs and PAs can do this. It's not limited to MDs.
Is that a recent kind of thing?
Yeah, so 2010 with the Affordable Care Act, I believe it was passed, and then just recently it was actually attached to like another bill that went through, and so Trump actually signed to extend it because it was like hidden in some other stuff. So we now have it's like infinite. If you have somebody who is experiencing withdrawal, and this is really relevant if you are going to do inductions and prescribe Suboxone in an outpatient setting, it's helpful to use the COWS, and you can like look it up online. There's like a easy to use calculator for this, so you can use that, and that way you have a standardized way of assessing where your patient is as far as withdrawal severity. As a general rule of thumb, the onset of symptoms occurs after 2 to 3 times the half-life of the withdrawn opioid. So there's quite a range in when that will be. And if you have a patient who you need to treat for symptoms, you can use clonidine, but then you need to remember to monitor for hypotension. Gabapentin can be used for pain. And Imodium is a great solution for the GI symptoms that accompany withdrawal. So Imodium is actually an opiate that can't cross the blood-brain barrier. So if you're going through opiate withdrawal, you have all these terrible GI symptoms, but we can treat that by giving the person Imodium because it's literally placing the opiate in the gastrointestinal tract, but it can't prevent the withdrawal because it's not going to get into the central nervous system. If you have a patient, if you acquire a patient who's already on a combination of opiates, benzodiazepines, other sedatives, something that looks like a risky combination to you, always consider consulting with a psychiatrist if the patient has a psychiatrist, or if you have one that you can ask if they have a lot of benzodiazepines and things like that for anxiety. Or talking to a pharmacist. A lot of pharmacists will be happy to go over your patient's medications and make recommendations on how to safely change things or what you should do for your patient. If you're prescribing and you're ever going to do something that's out of the ordinary, so like, for example, if I have chronic pain patients, I always prescribe on paper and I prescribe every month. Like I'm very consistent. I always do it exactly the same way. So pharmacies that regularly fill prescriptions for patients that I'm seeing will know, like that's what I do. That's, how it's done. But if you're ever going to deviate from that for some reason, so let's say if your patient is going to be traveling abroad for the next 3 months and you're giving them 3 times the amount, it's helpful if you note that on the prescription for the pharmacist, and that way they know what's going on, because otherwise they're going to get it and hopefully they'll catch it that that's abnormal, and then they'll call you and do this big back and forth trying to figure out what's going on. So it makes it a lot smoother if whenever you're deviating from what's normal, make a notation on your prescription explaining why. Another example is if you have a patient that you're maintaining on chronic opiates and let's say they break their ankle and they're on chronic opiates for back pain, you might give them some extra tablets temporarily for that broken ankle. That would be another example of, you could make a notation of ED visit this day, managing acute pain for this week or something like that, just to clarify what's going on there. When you're selecting an opiate, most people agree that you should start with a short-acting opiate, not a long-acting opiate. But there's some debate about the risk of addiction developing, whether it's riskier with short-term versus long-term. So the argument in favor of long-term is that if you have someone on a long-term opiate, then the peak and trough, within the therapeutic range, are going to be more consistent over time. So they're going to be taking, let's say, 2 pills every 24 hours. So it goes up, it goes back down. Whereas with a short one, you're going to keep going up and down, up and down, up and down. And there's some evidence that the quick increase in opiate might contribute to the development of addiction. But the flip side of that, the counter argument, is that if you have somebody who's always on this certain level of opiate, because they're taking round-the-clock opiate, they may be intolerant to that level, and then their new set point is higher. and then they need more to get above that, to get back into the therapeutic range. So and we don't really know the answer to that. So there's people that kind of believe either way. So that's just something to keep in mind, is we don't fully understand the mechanism behind why some people will go on to develop addiction, other people don't. It's all not fully understood. Are you guys familiar with cures? Okay, good. So I always check cures every single time I prescribe any controlled substance. I recommend that. You don't have to that often, but you didn't even used to have to check it. So that's actually really new. You didn't have to check. But I'm happy that they did that. Because a lot of people weren't checking before because they were like, it's just too much trouble to log in and look in the database. But sometimes you'll look up a patient and you're like, whoa, this patient is getting narcotics from 5 different places or something like that. But if you don't check, you don't know. And that's information that's available to you. So it's good to use that. I'll talk a little bit more on the next slides about clinic policies and urine drug testing. Make sure that you have a document that's a comprehensive pain management plan that has all the different things that you're going to be working on, including drugs and non-pharmacologic modalities. It's good to always counsel on risks of any treatment and consider prescribing naloxone for your patients that are on opiates. I mostly have done this just with people that are on higher doses of opiates, but there's really no downside to just getting more out there in the community because it won't cause any harm. This is a trainer you guys can play with. It shows you.
This trainer contains no needle or drug.
So this one is almost like an EpiPen. So
if you are ready to use your inject, place black end against outer thigh,
and then
press
just like an EpiPen uses. So
for 5 seconds.
So this is most similar to the brand name Overdose. I don't know if you guys read the news articles about the pharmaceutical companies like jacking up the price of that one. It's like $4,500 or something crazy. But the good thing is there's ways around that. One option, and this has become a lot more widespread. Years ago, I was able to even figure this out with a local pharmacy. The pharmacist was willing to dispense a syringe and like little amount to patients to essentially like assemble their own injector for $40, and that's now become more widely available. So it doesn't have to be like a makeshift thing so much as it used to now. A lot of people have access to it for like $20 to $40. And then there's also 2 different types of intranasal administration. So there's one that comes in like a really little thing, and then there's one that looks more like a syringe that has to actually be screwed together and assembled. So that one would be a little bit harder to use for some people that aren't medical personnel. But again, it's a good thing to talk to your patients about, especially if they're high risk for sedation or overdose, and also talk to family members if you can, because the patient isn't usually going to be the one to be able to administer it.
How many doses usually come in?
It should be 2. Even before, like, let's say back in like 2010, even back then, sometimes you would need to administer a second dose. Mm-hmm. Unfortunately, now in the last couple of years, there's been more and more cases where people are using like carfentanil or something like that that's way more potent, and 2 isn't even enough. So there are now cases where people will just keep getting doses again and again and again, and it just doesn't work. So I'm not saying like give up hope, but it's just like there are cases where you're gonna need more than what would come in a standard packet. So like for a clinic setting or an office setting, if you're working with a population that has a high rate of overdose or potential for overdose, it's probably a good idea to have that like either next to your fire extinguisher or like somewhere where it's readily available for clinic staff for the office setting, because you may need at least 2 doses, if not more, for some patients if they overdose.
Because I'm just wondering, like, whenever you give it IV, just the half-life of it is so short. So, like, when you give it subcutaneously, is the half-life longer? Or I'm assuming.
Well, so when you do that, like, it should be an IM injection. It still does not last very long. Okay. So that's another important point, is if you're out in the community, like let's say you're like working community health and you have a patient, very important to call 911 right away. because you don't know, you might do this and think, oh, great, they're better. And then 3 minutes later, starting to crash again. So this is good, but it's not like the magic solution.
Do they have to be breathing for the intranasal to work?
No, I don't think they have to breathe at all. Okay, and the last bullet point on this one, I also just wanted to emphasize that part of your pain management plan should always be how you're going to discontinue any therapy if you determine that it isn't working. So if it isn't meeting your patient's goals, you should have some sort of a plan written down on that initial document at the beginning of the process of what your plan is for stopping a therapy that's ineffective. This should be shared decision making. You should be talking about this with your patient. They should be completely on board with what the plan is, because you don't want to get into a situation if you don't talk about this, and then later on you determine, oh, this isn't working, I'm going to stop it, and then your patient is like, well, I never consented to that, or they're not on the same page, and that's not good. Clinic policies are really important, and I think this is especially important when you're new, getting out into practice on your own, because you can kind of go back to this if you get into a difficult situation with a patient. I think it's helpful for setting boundaries with patients and really clear expectations, both for the patient and for the provider. So this should include a urine drug tox policy or pill count policy. And you want to emphasize to your patients that the clinic policy is standardized, it's nothing personal, it's the same for everyone. It doesn't mean that you're judging them or anything like that, but your priority is their safety. So this is all about safety and trying to reduce risk. So you want to really talk through all these policies with your patient, not just have them in a binder somewhere that no one looks at. And then it's good if the practice as a whole has a policy, not just for pain patients, but for everyone, about behavior. It's not uncommon for patients to threaten you or to have inappropriate behavior in the clinic in some of these situations. So if you have a strong policy and management is behind you, it's much easier to say to your patient, hey, that was unacceptable behavior, this is how we handle it at our clinic. But if you don't have this policy and it's just you, then it's a much stickier situation, because then it's just saying, well, I didn't like what you just said. That's not really a good situation to get into. So if you use the institution where you work to say, this is our institutional policy, that's a much better approach. One example of why some of this is really important, I once had a 73-year-old woman who, her whole family had been going to this practice for decades, and I had seen her before, and she was frail, she used a walker. I was really concerned about her fall risk, so I spent like an hour with her and her daughter going through fall risk reduction strategies, talking about everything in their home that could be unsafe. We did this really thorough fall prevention plan with her. And then she came back, and at the next appointment, my MA told me what was going on, and then I looked at the test results because I'd done a urine drug screen on this patient at the previous visit. And it was positive for meth. And I was like, no, that can't be right. And so I looked it up online, and I was like looking at the different metabolites, and she wasn't on Adderall or anything else like that. So I was like, so I don't think it could be anything else. So most labs have a toxicologist who you can call to consult with on the phone, which is a great thing to remember. So if you're ever in doubt, phone a toxicologist. So I called the toxicologist, and I'm like, here's the situation, here's the test results. And she reassured me. She was like, nope, that is positive. Like 100% sure. She explained, it had been confirmed. Like, there's no way that it could have been a prescription stimulant based on the ratio of different metabolites. She's like, nope, that is meth. Okay. So I go back into the room, and I sit down with the woman, and I talk to her about the test results. And she says, oh, yeah, I used meth with my daughter like the night before that. I was like, oh. So that was like an example. We all have biases, and we can't always know what our biases are or how they're going to be affecting how we judge clinical situations. Things like this happen to everybody. We as clinicians are actually not very good judges of who is at high risk for overdose or substance abuse. So that's why it's really important to have a standardized approach with all patients. Because like in that example, it would have been really easy to say, oh, well, patients over age 70 don't need urine drug screens, right? But that would have been wrong, because this lady, for her safety, really needed to be, counseled, and her treatment plan needed to be reconsidered given her meth use. This is a piece of what I actually used to use. I had to make my own policies because I was working somewhere that did not have any policies. So this is what I came up with. It's certainly not perfect, but it's just an example for you guys to see what you might use in practice. A couple things about these, if you end up writing your own in the future, try to avoid using the term narcotic contract. That was used initially and has become, it's really like stigmatizing term, especially the word narcotic. People associate with like DEA raids and all this negative stuff. And like what I was talking about earlier with, this isn't just about opiates either. This is also about benzodiazepines and other drugs. So I think controlled substance agreement is a much better term, because then you can use it for patients on benzodiazepines and other things, and then it's not as strange to your patient when you're having this conversation about safety and why this is important. Yeah.
What's your approach to the patient when you get some unexpected results on the cures report?
Yeah, so I usually will just sit down with patients and ask them, because you'd be surprised how many patients, like that woman saying, oh yeah, I use meth. Like a lot of patients will just be really frank with you when confronted with something like that. So like you might sit down with them and say, hey, I noticed that you're going to 6 different doctors for your narco. Could you explain more about that? And, just ask them, and a lot of the time they'll just tell you. There can occasionally be situations where people are not forthcoming, and then you may need to kind of backtrack and take a different approach. But I think also that goes back to like having policies. Like if you have a patient who's not forthcoming, will not talk to you, who's just like not communicating, then you can say, well, I'm sorry, but for your safety, we can't give you this certain drug anymore. And that's often a time when I would also try to talk to people about substance abuse. And if they clearly are in denial, like you're looking at all the signs, you're thinking, okay, this patient probably has a substance use disorder, you can try to talk to them about it. And sometimes patients will, like in that conversation, like I've had people just like break down in tears and be like, oh my God, I really do have a problem. So sometimes just having that conversation with your patient, you might get somewhere. You won't always, but it's worth trying, because sometimes you will. And sometimes you can then refer that person for treatment or try to get them into a safer treatment plan. It's also really important to emphasize that if patients are not able to follow the agreement, you're not going to abandon them. You're still going to treat their pain. So that's another thing that, like, historically, there's a big stigma isn't quite the right word, but a lot of patients will come into this conversation thinking, oh no, if I mess up, then you're not going to treat me anymore. You're going to like kick me out. And they think that there's going to be these disciplinary repercussions if they like mess up. And you have to kind of explain to a lot of patients that's not what this is about. Like, this is about your safety. So I'm going to treat you. There's a lot of different treatments for pain. It's not all opiates. So you have to kind of be demystifying some of those myths that will keep coming back from patients. It's important to always remember to give a copy to the patient in addition to their individualized treatment plan. I think that's true of everything, not just pain management. Whether you're doing diabetes or hypertension, like whatever you talk about with your patients, it's great if you give them a physical plan on paper, especially if you're working with geriatric populations. A lot of people really appreciate having tangible plans, because then they can look back to it and say, oh yeah, that's what we talked about after, especially if it's a lot of information. Like these agreements, it's really a lot to remember. So it's good if they have that in hand when they're leaving so they can go back and review it. It's also important to talk about expectations for communication as part of this conversation. It's best if you have office staff or colleagues who can support you. Like some practices, one provider is always on call and carry a pager in primary care, whereas some don't have that strategy. Instead, you're not on call, but then there may be like an LVN or someone else who will take calls when you're not there, and can at least kind of triage a little for you. So there's different setups depending on your practice, but it's important for the patient to know that they always can reach someone who can then reach you if they have something happen with their treatment. And that kind of goes the other way to, like, if, let's say they know that they're going to need more opiates because they just had a root canal and, whatever, something happened. It's important for them to feel open to calling you or calling someone on your staff to say, hey, this happened, this is what's going on, this is where I'm at. Because if you don't have that open communication, you're going to have a lot more situations where people just shut down and won't talk to you, or you find, on cures, they went to some other people and got the same drug, and you don't want that. So if you can keep the communication open and both be honest with each other, then you're more likely to have a situation where you're able to have a successful treatment plan. So with urine drug testing, in general, the first test you're going to use in the office setting is an immunoassay. And then if that is positive, then it'll get confirmed with gas chromatography, mass spectrometry. Some practices will have this, like what the picture is like, that's a really simple like immunoassay strategy. It's really similar to reading a urinalysis in the office. Those are not very accurate because they only look for drug classes, not for particular metabolites. So that can be a kind of helpful like initial screening, but you can't read into those results that much. So if that isn't what you were expecting when you see the results, you definitely should send that to a lab and do confirmatory testing to know what you're actually dealing with. And similarly, a lot of those office type tests will miss a lot of things. Like a lot of benzodiazepines won't show up, fentanyl typically will not show up. So these can be a good tool, but it's just important to know what their limitations are as well.
Do you ever do the hair testing?
I never have, and I don't know how much that costs. And I know a lot of that is changing these days, but I've never worked anywhere where I could do that. But I would imagine maybe with some private insurance, you might be able to do stuff like that. I'm not sure. But I've mostly worked with people that are like Medicaid, Medicare, or self-pay, low-income people. So I have less experience with like fancier testing methods. So another thing to be aware of is there's a lot of ways to produce false negative results. So some of this can be mitigated by training your MA in how to collect the specimen. For example, putting blue coloring in the toilet, having the water turned off in that bathroom, having your MA actually not closing the door fully, watching the patient. And it depends again on where you work, but you as the nurse practitioner may be training your MA. So it's important for you guys to all know a little bit about those procedures because you may have to be training somebody how to do that. And that can help a lot, but people still will buy urine and, there's all sorts of different ways of getting around it. But if you send it out to a lab, then the report will come back and it'll have the pH of the urine, how dilute the urine is, and they'll usually test for common things like bleach or vinegar, things like that. So you'll get that on the report. So okay, well, this was not a real result,
I noticed marijuana isn't on there. Do you not usually screen for it because...
I don't, personally, but
Yeah.
that's my
Yeah.
personal... So the reason why I don't is because, and this definitely may have changed. I haven't looked this up because I haven't been in like a independent primary care practice in a couple years now. But back then, some patients would lose their insurance benefits if they had a documented positive THC result in their medical record. And so after I learned that, I was like, oh my God, I've never tested for it again. Because instead I talked to my patients about it. Like I don't want it in the record for every patient. Because again, this is consistent. Like if I have a policy like this, I think it should be every single patient. But if someone is using marijuana appropriately, that's great. I don't want to get in the way of that. So I think it's better. And again, the legal aspects around this are changing constantly, so it's really complicated. But it's something to be aware of depending on what state you're in and whether it's federal money paying for the care versus state money. There's a lot of different factors to consider. But just remember that the medical record is a legal document. If you document something like that, it's there. You can't take it back.
Even if it's like legally prescribed.
So that it might not be an issue anymore if it's like medical marijuana. I'm not totally sure. Because again, my knowledge is out of date on this one. But years ago, it definitely was something that I had concerns about with some patients depending on their insurance. But yeah, I don't know. I'd have to look into that.
Do you does it cause respiratory? Because so many people do use it who have pain. Does it increase your likelihood of respiratory depression?
Yeah. So unfortunately, we don't have very good data because there hasn't there's so many restrictions on federal funding for researching it that there isn't good data to look up. But we do know, even if you look on Up to Date, you can see a lot of things will warn you where there's an increased risk of sedation, for example. So I'd say a lot of the time you could treat it almost like it's a benzodiazepine or something like that. I would definitely consider it in the same realm of other medications that you may be using for pain or anxiety. So yeah, definitely counsel your patients on the risks and possible drug interactions because could be a problem. Related to drug metabolites, it's important to remember when you're reading test results that what you prescribe is not what comes back in the urine. So the metabolites can get a lot more complicated, and you can always look it up. And if you can't figure it out, I go back to my phonotoxicologist advice, because you may get a situation where you're like, why is this metabolite in there? I don't know what this is. So you can usually call whatever lab you're sending urine to and ask their toxicologist on the phone. It's really confusing. But it definitely can get a little complicated. So, I think it's interesting, heroin in general is going to turn into morphine. So if you're prescribing morphine and your patient is also using heroin, it's possible that you could do urine drug testing and never see anything different about that. So I think being a little familiar with this is helpful, also to know the limitations of testing. Urine drug testing is definitely not perfect, but we do have some evidence that it can help support patients in doing a better job with their care. So it's probably a good thing to do. It just isn't always going to show you everything the person has taken or not taken. So we talked about cures. It's good to always ask your patients how they're taking their medications, both because a lot of patients might be taking medications less frequently, or maybe they're taking all of them in the morning or something. A lot of patients will change things a little bit from what was on the initial prescription. So it's really important for you to know how are they actually taking their medication, how much are they actually taking. And if you run into a situation where your patient is like, oh, well, I'm only taking my medication twice a day, so they need 60 tablets per month, but you look and you're like, oh, we've been getting 90 a month. And you can just say, I think I'm going to reduce that for you, and that way you won't have extra pills, So a lot of the time there's things like that where you need to make a little bit of an adjustment if you find out how the patient's taking it, because sometimes they may be on something that was prescribed many years ago and no one has asked them that question. So that also can look strange on cures, because you might notice that they're refilling every 45 days or something like that. And it's like, that's odd. And then if you talk to them about it, you realize, oh, that's why we're giving you too many pills for a 30-day supply. Remember to reassess pain, and it's good if you can use the same tool that you used at the initial visit over time. And that way it's easier to compare how well the treatment is working. It's important to talk about daily function and how the patient feels about the effectiveness of the treatment, because it is really important whether the patient feels like it's working or if they feel like it's not working. You have to really get their input on what do they think, because they're going to be the best judge of their pain and their pain control. And then revisiting the goals of care over time is important to see how they're progressing, and then evaluating what treatments you're doing. So if the patient has been in physical therapy for 6 months, let's say, and their goal was to be able to walk up 2 flights of stairs without stopping, and they haven't made any improvement, let's say, as an example, you might want to talk to them about, oh, okay, like what's going on there? How can we adjust that? Maybe this isn't working. Whatever it is that you're using as treatment, you have to reevaluate if the patient isn't progressing towards whatever goals they set. It's always really important to document your clinical decision making, because you should always be in your head thinking about risk and benefit of everything that's going on. And you want to always document that in your note, even if it's not something that is like off-label or abnormal in some way. You always want to document. That's really important for you. It's important for patients. It's important for everybody to have that written down. And that can be like a lot of this documentation can sometimes be a liability issue. Like you definitely want to have in the patient's chart what you're doing and why. Because if something ever does go wrong, you want to have that documented. For a physical exam, it's important to reassess your patient, similar to talking about their goals, actually checking and seeing how things are changing over time. And if you do decide to escalate an opiate dose, that's especially important to document why you decided to do that, what your rationale was. You don't ever just want to say, oh, I'm just going to increase the dose without explaining why you made that decision. So one definition of opioid failure is up here, but there's not a standardized definition. So 120 morphine equivalent dose was a level that was used really commonly years ago, and more recently, a lot of organizations have started lowering what is considered high dose. So you'll see some places in the literature it'll say 100 milligrams morphine, some places are now saying 80. So it's not really a agreed upon level, and the definition of what constitutes opioid failure also is not really standardized. But I think it's helpful to have a working definition, just have an idea of what that might look like. It's important to always communicate your concerns to the patient if you think that you are dealing with opiate failure, and to have a firm but supportive attitude when you're tapering or transitioning to a non-opioid. And then the DSM-5 has a clear definition for opioid use disorder, so that can be helpful to review to look at the exact diagnostic criteria. Okay, question for you guys. Okay, so it's definitely not A. That's saying that I think a lot of people use as a reason, but I think that's a disservice to your patients unless you're truly not professionally competent, in which case you should become competent, learn more, go back to school. But I think just saying, oh, I'm not comfortable, if you're the primary care provider, you should be comfortable treating your patient. And if you're not, then you should find someone else who is. But I think you do have an obligation to your patient to treat their pain and to be able to provide a range of different therapies. If there's like arbitrary cutoffs, like I mentioned the whole like 120 versus 100 versus 80, and you may work in a place where management may tell you something like, hey, you need to get all your patients down to 100 milligrams of morphine equivalent dose. That's not really good care, because it really should be individualized based on the patient. It shouldn't just be like a arbitrary standard across the board that you're just going to apply to everyone. And it's not a punishment. I think that's another important thing to emphasize to patients. A lot of people will feel like they're being punished if they are having their opiate tapered. That's not the goal. Oh, one other important note about that is it's all tied to the goals of care. So it's important to always remember that in a broader sense. So for example, if you have a patient whose goal of care is comfort because they're at end of life and you're providing palliative care, do not taper the patient. That does not make any sense with the goals of care. But some people have, like I've read about people doing that. It does not make any sense. So it's all about the goals for that particular patient. Does anybody want to read this out loud, or do you guys want to read it on your own? So I wanted to have this as an example because there is a subset of patients for whom long-term opiate therapy is actually really helpful, and denying them that could be harmful. So the answer for everybody is not taper everyone's opiates, get everyone off the opiates, because there are some cases like this one where it's actually working really well for that guy. So, for his goals of care, if his goal was to be able to walk his dog, that's great. He's doing it, no side effects. That looks great. So there's a few different types of tapers. There's actually even more than this, but this is what I think is most relevant to talk about. So in general, provider directed would be like if I say, okay, well, we're going to decrease every month, we're going to decrease by this amount. Whereas patient directed, you can use if you have a really motivated patient who wants to try to taper themselves, and if they seem like they're really stable and seem like they're going to be able to do that well, then you can empower your patient to taper their own medication over time. So that can be great for some patients, but it's certainly not for everybody. Because tapering opiates is really hard for most people. But there is the rare patient that's just like, yep, I'm going to get off them, I'm going to do it. And like they can sometimes taper much more quickly than you would if you were guiding the timeline. There are equal analgesic dose calculators online. And then there's morphine dose equivalent, I already mentioned. It's important to note those aren't like the same, and you can like look online and find a morphine dose equivalent calculator and then an equal analgesic calculator. They're a little bit different, but they're both online. And even with the correct calculator being used, it's not perfect because it doesn't account for genetic factors, incomplete cross tolerance, or pharmacokinetics. So if you're about to start someone on a taper and you're trying to convert from one opiate to another, it's good to always be aware and to talk to your patient about that's not ever going to be perfect. Like a lot of this is not going to go smoothly. A lot of things are not as predicted because everybody responds a little bit different to these medications. So just by calculating it, you can't know that it's going to go smoothly. So if you're tapering somebody, they may experience mild withdrawal symptoms, but you don't want them to ever go into moderate withdrawal symptoms. Like so if they're like yawning, they have watery eyes, most people will be fine with symptoms like that. But you don't want to send somebody into more of a withdrawal, especially as an outpatient. Like that's just not good. So in general, you're going to aim for a 10% reduction from the initial dose. And one reason why it's good to convert to a short acting with like small dose pills is because if you are trying to taper a drug that only comes in like 3 pills, for example, then it's really hard to make that, if you're thinking, okay, 10% reduction every month, you can't line that up. It doesn't work very well. So if you can convert to something where you can more easily say, okay, we're going to decrease by this small amount and this small amount and this small amount, then they're not going to be like cutting tons of tablets into little fractions and stuff like that. And then deciding on the timeline depends on the patient. So I definitely be open to what the patient's input is and what they want to do, what they think they can do. In general, if someone's been on opiates for a really long time, they're going to need a long time to reduce the dose. It's going to have to be really gradual. But some patients may be super motivated and they want to try to do it faster. And then you always want to check in with your patient frequently. And it's totally fine to pause a taper. If let's say if the patient gets through the first third, the decrease really well, they're doing great. And then they hit a point where they're just like, oh, I can't do it. This is not working. Just hold off. It's okay. You can delay. Just keep them at that same dose. And when they're ready, you can try again. It's much better to just wait because most people will have times, especially after the first third, where they're going to really be struggling with it. And it doesn't mean you should give up and just stop. It's better to just hold them at that dose until they feel like they're ready to try to decrease again.
If they're seeing a mental health care provider, if you're prescribing any of these drugs, do you always contact them, or?
I guess it depends on where you're working. So, when I was in a small private practice, it was just me. And if someone had a psychiatrist, I would try to call the psychiatrist and try to coordinate with them whenever possible. Like I had one guy who also was using meth, but he was on multiple medications from my predecessors where I was working. And then he also was getting benzodiazepines and some other stuff from a psychiatrist. So I worked very closely with that guy to coordinate that patient's care because the patient had so many medications and so many different issues going on. If you work at a federally qualified health center, like community clinic kind of situation, often you may have a social worker or someone on site, which is great. So if you have that resource, I encourage you, for any patient that has any anxiety with tapers, which is almost all of them, you can pair visits with your social worker or psych NP, whoever it is, and that can be really helpful. So like in my first job, I was in a situation like that. So I would often see patients for chronic pain, and I do the medical stuff, and then I'd hand the patient over, and they would go talk to the social worker for therapy. So I think if you have that resource, definitely utilize it for your patients, because a lot of people find that really helpful, because it's really stressful to be tapering their opiates. So if they can go and talk to someone about that stress right then and there, that's great. One thing to remember about if you're tapering somebody using a short-acting opiate is the half-life is shorter. So like oxycodone immediate release, the half-life is like 4 hours. So they're going to need like 6 doses a day. So they're going to have to wake up in the middle of the night to dose. So that could be an issue for some patients if they've been on long-acting opiates for a long time. You'll need to remind them and talk to them about that. Like while they're doing this taper, they're going to have to get up and take medication during the night. Otherwise, it's going to be out of their system. When you're tapering people, it's totally normal for the pain that was initially present when the opioid was prescribed to return. That's associated with withdrawal, and that's really common. So like, let's say someone has like a broken elbow and they've been on opiates for a really long time. When you start to taper those opiates, their elbow is going to hurt really bad. And they might come back and be like, oh man, there's this problem with my elbow. And it's a normal response. It's very common, but it relates to those damaged nerve fibers. It's not that there's a new physical problem, it's the neurological problem showing itself. So it's important to talk to our patients about that being an expected thing to happen, but it doesn't mean that they have some new thing going on. That's just because the opiate is being decreased. A lot of patients will also say it takes the edge off if you ask them how it's working, and that should not be considered efficacy. So it takes the edge off is really just telling you that it's preventing them from going through withdrawal. And we know that, that's not helpful, and that doesn't mean that we're appropriately addressing their pain. So if that's the only thing in favor of keeping someone on an opiate, then the treatment is not working. It's also important to tell your patients about post-acute withdrawal syndrome, which is something that can happen up to a year after they've been off of opiates. So your patient may have an episode of anxiety and pain just kind of out of the blue. They may think, oh, I don't know what's going on. They may go to the emergency room. It's really important to talk to your patients about this, because it could happen. It doesn't happen to everybody. But if it does happen, it's important for that patient to know they should not go to the emergency room and get opiates to treat it, because then they're just going to go back and then start the whole thing all over again. So that's another thing that is a consequence for some patients. Post-acute withdrawal syndrome can happen, but it's good to just be informed about it and know that it's a possibility. Oh yeah, another point is if you have a patient and when you have that conversation about how are you taking your medication, and they say something like, oh, well, I take it like maybe every other day, maybe like 3 or 4 times a week, something like that. If they're not taking it every day, you don't need to taper. That's great, because you just stop it. So if it's not working and they're not taking it every day, that's easier for you. Just stop it and the patient will be fine. So it's only in cases where the patient is taking it every day for a long period of time where you need to do a taper. I mentioned that it's easier at the beginning and then tends to get harder. And at the end can actually be the hardest part of a taper, which seems kind of counterintuitive. You think that if people were like almost done, they just want to finish and get it over with, but that's not the case. A lot of people have a lot of trouble with the very end. So they'll just be on a small dose. And even if they want to get off of it, it may be really hard for them. So they may need a lot more time on a smaller dose before they're ready to stop it. Another bad thing about UpToDate I noticed while making this talk was, UpToDate, it says to reduce by 25% on some of the things I was looking at. I was like, so that would be a rapid taper, but that's not what you're going to do. For most most patients in primary care. That would not be very nice. So if you reduce people's dose by 25%, most people are going to go into withdrawal, they're not going to be happy campers, and they're probably going to go to someone else who's not going to taper them back. So that's not really professionally responsible, because then you're essentially just moving the problem over to another provider.
What's the average time it typically takes your patient to taper?
Like, it could be a month, it could be 3 weeks, or it could be years. So it's like all of
So the 10% reduction, are you doing that on a kind of a?
So you start out with 10%, and then, obviously if you recalculate that every month, then it would just be growing. That's not what you should do. So you do 10% of the initial dose and plan out like what you estimate your taper time is going to be. And that's like based on what the patient wants, like what you think is reasonable based on how much they're on, how long they've been on it, other factors. So like if they have anxiety and depression and a lot of other things going on, they might need a much slower taper. So you have to really, think about the whole individual patient when you're planning that. And then you'll plan to do a 10% reduction at whatever interval you picked. And then you may, at the last third or something, depending on the patient, you may stop for a while. And then you may revisit it and try to figure out what's going to work again. So that 10% is where you're going to start with, but it's a rule of thumb.
Okay.
So for some patients, you may need to do 5%. You may need to, you have to kind of adjust it. None of this ever goes perfectly. So you always have to kind of be willing to change things based on how the patient reacts.
Thanks.
When people are discharged from the hospital, how often do you feel like you take over prescribing?
The second place I worked when I was in the rural small practice, that was a really fairly common thing where I would often get phone calls sometimes from surgeons. It'd be like, hey, so I'm going to do a total knee replacement on your patient and you're going to manage the pain. I'd be like, no. Some people will literally do stuff like that to you as a primary care provider. And it's like, that is not professionally appropriate. If you're going to operate on someone, it should be on the surgeon to do the post-op pain management. So you may have situations where you need to put that back on a surgeon or whoever it is that's also treating your patient. Because you as a primary care provider are responsible for their overall health and coordinating their care, but you're not responsible for inpatient care or there's definitely limits. We're not responsible for everything.
If a patient has healthcare access concerns or insurance concerns, is it possible to basically do this rapidly instead of the slow taper process?
I would advise against that in general. Even if if there was one patient I had that was driving 2 hours or something to come see me, just was in such a rural area. But I still was having her come in regularly because it's still, I guess one thing about rural patients or people that have a lot of trouble coming into the office is a lot of the time it's those same people that are higher risk for other things happening, So if it's at all possible, I try to see the person just like you would everyone else. A lot of places will have a sliding fee scale, so it might only be $10 for them to come for a visit or something like that, which can be really helpful. And you can try to work around that a little bit, or even in some cases, you may be able to transfer care to somewhere closer. If it's if they live so far away that they just can't get to you, you might not be the best primary care provider for that patient if it's that much of a barrier for transportation. But in general, I think it's not a great idea to say okay, well, this patient has to drive 2 hours, so I'm only going to see them once every 6 months. I wouldn't do that because reassessing pain and monitoring, especially for prescribing opiates, is really important for their safety, and for the whole process.
Can you clarify what you mean when you say people who are less able to come into the office are at higher risk for addiction?
I just meant if you have someone who's living in a rural area and they have very few resources, it might be beneficial if you can provide them with more support. So let's say if you have someone who lives in a really rural area and they need to see a therapist and they need a podiatrist and they need, they have all these different needs that little town doesn't have those resources. But if you can get them to come in once a month or once every 3 months, you might be able to help that patient with their whole overall care a lot better. So if you have somebody who's isolated like that, it's really harder to provide them with high quality care. Some people now can do telehealth, which can be really beneficial for rural patients, but you can't provide the range of services with something like telehealth that you can if you can get that patient in to see a whole multidisciplinary team. So I think it's ideal if you can do that, but obviously there are very real barriers to consider.
Do you ever deal with issues with employers? Like if you're doing a long-term taper on somebody and like their employer drug tests or something like that?
I haven't had, I guess, anyone come with an issue like that before, but you can certainly always provide a note for workplaces about your patient's health conditions. Like you could provide a note saying, I am a primary care provider, I am treating this patient, here's what their drug test should say or whatever. Like you could, whatever the situation is, you can tailor it. But you can always provide documentation for your patients if needed for something like that. It's good to know what the limitations are of yourself and also your practice. So related to resources in your practice, if you're in a little clinic somewhere, you might not be the best place for some patients if they need a lot more support. So for example, if you work somewhere with a social worker on site, I think you can see a lot more patients who need counseling at the same time. But if you don't have that resource, you might want to reconsider if there's somewhere better to help particular patients. If you do determine that your patient has opioid-use disorder or another addiction, it's really important to get them treatment, not to taper them. When it relates to what care is needed, that's one reason why I think it can be important to make that distinction, whether it's tolerance, dependence versus addiction, because your treatment can go different ways depending on which of those two things it is. And then if you're not sure what the pain diagnosis is, that would be another reason why you might want to refer to someone else. If you just have a really complicated case you just can't figure out, you might want to see if you can send that person to a pain specialist or someone different. Okay, first case. We don't have that much more time. Do you guys want to express ideas as a group to go through it more quickly? Okay, so here's the questions, and then let me know if you want me to go back to that one.
Thanks. Alcohol use with.
Okay, yeah.
All.
Sorry, what?
All.
Yeah, all, yeah.
Some years.
Yeah, yeah. So that's always a good red flag is like quantifying alcohol.
But how do you phone in is detox? Or is that?
So that is one of those things that's kind of confusing because it's an expected metabolite for this guy. There's silence with his prescriptions that I put in there as a red flag. Well, yes. Yeah, so it's a really high dose for sure. What else about his prescriptions would you consider a red flag?
You have the Norco with morphine.
Yes. So duplicate therapy is a big red flag you should always look out for. So if someone is on too short-acting opiates or too long-acting opiates, something like that that just doesn't seem to make any sense clinically, that's a red flag. What do you guys think? Yeah. Why or why not?
Because pain is not controlled by me.
So this is actually based on a real case. When I first got out of school, this was like one of my first patients that I acquired. And I tapered him. Yeah. So you can't, even though like this guy was resistant and not super excited about it, but still did it.
Tell him to move off the boat.
That would be one of those difficulties that you can't easily address. But yeah, I mean, ideally that would not have been a perfect situation for him. What do you think about for goals of care? Home safety would even be one.
Down to functionality.
If he lives on a boat, I want to know, is there a committee on him?
Yeah, so talking to patients about their social support network is really important. because patients tend to do a lot better if they're not socially isolated compared to if they have a lot of social supports in place. So if we had more time, I was going to have you guys outline a step-by-step paper plan. But in general, what would your first step be for this guy, given what he's taking right now?
He's given or
You could do that. That's one option. With this, there really aren't right or wrong options. It's really up to your discretion. What other choice might you think of?
In your slides, you outlined like 10%.
Yep. In real life, like, and this isn't, I didn't remember off the top of my head exactly what the actual patient was taking, but what I ended up doing was converting to only one type of morphine, because having two different types, having the long-acting and the short-acting, was like, no. So I converted from long-acting to short-acting first, and then started to taper. The other thing is you only want to taper one thing at a time. So you might look at this and think, oh man, we should taper all three of those medications. But don't like try to take on multiple things at the same time, because that's just going to be too much for the patient. So if you just work on one thing at a time, that can be a really helpful strategy, especially if you have patients that are on multiple different drug classes that are all not helping the patient. So like if you have someone on a benzodiazepine that they initially were prescribed for sleep and they've been taking it for years and years and years and it's not working, you can have all these different classes of medications that are just like this. So this whole like theory and strategy can be applied to other drugs as well.
I think it's harder. The taper, like I know your slide before said you convert to short acting small dose, but in this case we're not looking at small dose because I'm worried about the bump.
Yeah, that was a very real issue. So I actually like drew all of this out when I did it, because again, this was when I was like literally like just graduated. So I kind of like drew, I was like, okay, so you got 60s and 30s and 15s, and like it's like a puzzle. And you'll have situations like this where it really is a puzzle. And so then you're doing the math, figuring out, okay, well, ideally I'm going for 10% of this total dose, and then how do you build out of the pills available that dose? So it's complicated. It's often messy and not straightforward. So yes, that is a real issue with this. But at the same time, I think sometimes because there's incomplete cross tolerance between different opioids and different patients who respond to different individual drugs a little bit differently, there's also some risk involved in converting to a completely different opiate. So you have to really weigh it. There's no right or wrong answers. It's individualized for patients, and this is something that we don't have very much scientific evidence to back up right now. This is a fairly new problem, and so a lot of this is clinical judgment. It's not something you can look up in a textbook and have a perfect guide to how to do this.
Do you think having a pharmacist to consult with would be helpful in making a clinical decision?
Yeah, absolutely. That goes back to resources. So much of your job will relate to what resources you have available for your patients. So if you have a clinical pharmacist on site, that's awesome. Utilize that. Depending on where you're working, you might not have additional resources for your patients.